Thank you for joining tonight's discussion on prostate cancer. Today we have Dr. Rachna Chinnamaneni. Ma'am is an associate professor and the Department of Medical Oncology from Nizam Institute of Medical Sciences, Hyderabad. Ma'am, over to you.
Thank you, Sandeep. Thank you for giving this opportunity, and thank you, Bayer, for this discussions on prostate cancer, which is actually an important malignancy which we do come across in our daily day-to-day practice. It is different from other malignancies, being the commonest presentations in the elderly age group who have their own other issues like other comorbidities. You have their polypharmacy, the falls, and various other things which are unique for the geriatric population. In the same way, prostate cancer, majority, almost 90-95% of the patients are seen after 60 years of age, very few presenting in the younger age group. So this tumor is something which has its own unique presentation. It is one of the malignancies in stage 4 in the solid tumors where you have an option of surveillance, active surveillance also, not in the stage 4, sorry, in the early stages, where you have the option of active surveillance. Very few solid tumors have this option of active surveillance. So prostate is one of them. So when now today's our discussion would be mainly for the metastatic setting of the prostate cancer, not the early stages. So I won't waste much time. So I'll invite our speakers for today. For the first talk, I would like to invite Dr. Nikhil, a good friend of mine, working as a consultant at Vasatarkam Indo-American Cancer Hospital from Hyderabad. Dr. Nikhil, over to you for reaching the new heights in metastatic HSPC care.
Yeah. First of all, thank you, Bayer, for this opportunity. And thanks, Dr. Rachna, for that introduction. I'll just try to share my screen.
Yes, sir. You're audible as well. The slides are visible, sir. Please proceed.
Yeah. Yeah, just a second. Yeah. So we all know that prostate cancer has got a classical step-by-step evolution in terms of disease progression. It usually begins with localized or locally advanced prostate cancer. And then once we do some sort of local therapy, either surgery or radiotherapy, some patients tend to have recurrence of the disease. The earliest form of recurrence is usually picked up by the rise in serum PSA again, which is called the biochemical recurrence. And sometimes some of the patients might not only have a biochemical recurrence, they might also have disease which is full blown, in the sense they can have multiple metastatic disease sites, which is usually labeled as metastatic hormone sensitive prostate cancer. While some patients on biochemical recurrence after appropriate treatment for the same might relentlessly progress, and we have a small proportion of patients who fit into this category of non-metastatic castration-resistant prostate cancer. Eventually, for a vast majority of the patients who have advanced disease, they progress from a castration-sensitive state to castrate-resistant prostate cancer. And ultimately, once the patient moves from this to the CRPC state, we have got limited options, and ultimately there will be a relentless progression of the disease leading to death. So we can see here that the median overall survival once the patient enters into this CRPC is usually in months, 6 months to 8 months in the current era. So what we try to look is the current subgroup of patients fitting into this metastatic hormone sensitive prostate cancer stage, wherein what can be done so as to prevent this transition from a sensitive prostate cancer to resistant prostate cancer. So any opportunity to delay from switching this sensitive to resistant stage ultimately leads to better survival outcomes. So we have got evidence from the Stampede trial. The Stampede trial was the earliest to evaluate what can be done to improve this set of patients apart from the baseline ADT. So this particular subgroup analysis, which is shown here, is from the STAMPEDE trial, where the patients with newly diagnosed metastatic prostate cancer were treated with ADT and docetaxel. Here we can see that the median failure to time to failure is 11 months, and the median overall survival in the docetaxel era is about 42 months. So a lot can be done in this set of patients in terms of additional therapies, which might actually increase their uh, disease progression-free survival as well as overall survival. So the Stampede also looked at what can be done beyond that of ADT and docetaxel. So the Stampede trial categorized patients basis of what they looked at was the set of patients who have got low volume or low risk disease, that is less than 4 bone metastasis. And if this set of patients, after having an achieving an adequate response after docetaxel based chemotherapy, if some sort of local therapy, more so in the form of radiotherapy to the prostate and pelvic nodes, can be done, there is definite improvement in terms of the failure-free survival as well as overall survival. However, when a similar strategy is applied to those patients who have got higher degree of disease, that particular strategy was not found to be useful. So this has shown some evidence that for a limited disease or a low risk disease, uh, ADT, docetaxel, and some sort of local radiotherapy is beneficial. And following this, there were multiple studies where the newer anti-androgen agents were examined or studied in this particular metastatic hormone-sensitive prostate cancer setting. So the charted, STAMPEDE, as well as the GETUC trials looked in ADT plus docetaxel. And the later came the STAMPEDE as well as LATITUDE trials, where abiraterone was tried along with ADT. And then came the series of enzalutamide trials in the ARCHES as well as enzalutamide trial, which was again followed by the apalutamide in the TITAN study. So this was till then was more or so in combination of ADT plus novel anti-androgen therapy, which was compared with ADT plus docetaxel or ADT alone. We can see, as mentioned in the table here, the hazard ratios gradually kept on increasing with the advent of newer anti-androgen agents. But what was more interesting is the approach of a combination of all these strategies, that is the PEACE trial, which is the docetaxel plus ADT plus abiraterone, as well as the Arasens, the current trial or the latest trial, where the best novel anti-androgen therapy, that is darolutamide, was combined with docetaxel and ADT. So the current Arasens study, we can see that the hazard ratio of, for overall survival was 0.68, which was quite impressive. So with plenty of options available, how do we choose what particular strategy needs to be applied for a patient? So we go through some of the pivotal studies in terms of their PFS as well as OS and what benefit was shown with their particular strategies. So the first is the charted study, wherein ADT plus docetaxel was combined with or compared with ADT alone. So in the charted study, the patients were characterized on the basis of volume of disease, that is a high volume or low volume. High volume included those patients who have got visceral metastasis or has got more than 4 bone metastasis, one beyond the vertebral column as well as pelvis, or the Gleason score of more than 8. So the ADT plus docetaxel showed an improvement in terms of median overall survival. Uh, the median OS was 50 months versus 34 months in the placebo arm. So that's an absolute improvement of about 16 months. While again, the same strategy was not statistically significant in low volume disease. So this showed some light that in those patients who present with tons and tons of disease, chemotherapy was beneficial. Again, the same in terms of the latitude study, where instead of chemotherapy, here abiraterone acetate was used, and it also analyzed patients on the basis of high risk and low risk categorization, where high risk included those patients who have got more than 4 bone metastasis or visceral metastasis or Gleason score of more than 8. So again, this has shown that in high risk patients, the addition of ADT along with abiraterone acetate was beneficial in terms of overall survival. And initially, there was a lot of apprehension in terms of side effects as well as the amount of or the dosage of steroid which needs to be used. But again, even 5 milligram once daily, which we also tend to use in patients who have got poor diabetic control in clinical practice. Again, we can see that slowly all of us have learned to manage the adverse effects of abiraterone, and we are a little cautious in terms of patients who have got fluid retention or cardiac issues. And we usually check for these parameters whenever we try to initiate some of these patients on abiraterone. Coming to the Titan study again, so this study compared ADT plus placebo versus ADT plus apalutamide. Again, the study has shown benefit in terms of the progression-free survival as well as overall survival, which was statistically significant, and the benefit was seen across both low volume as well as high volume subgroups. Coming to the enzyme study again, enzalutamide plus ADT was compared with placebo plus ADT. So again, there was benefit in terms of clinical progression-free survival as well as overall survival, and the benefit was seen in both low volume as well as high volume disease. So what is this combination approach therapies which can further increase or improve the outcome for these patients? So we have got the P strategy where the patients included were de novo metastatic hormone sensitive prostate cancers. And this study for a vast majority excluded those patients who have received prior chemotherapy with docetaxel. It included patients who have got higher low volume disease and good performance status. So the patients were randomized to four arms. One is the standard of care therapy, that is ADT, and the other arm is ADT plus radiotherapy. Then the third arm is the ADT plus abiraterone, and the fourth is ADT plus abiraterone and radiotherapy. So when the ADT docetaxel and abiraterone was analyzed in patients who have got high volume disease, we can see that the median overall survival was about 5 years compared to 3.5 years in the placebo arm. And the difference was numerically better. However, it was not statistically significant in the low volume disease. So this again led to confirmation that the high volume disease needs chemotherapy, which would improve the outcomes in terms of PFS as well as OS. But the same benefit was not translated when patients with low volume disease were treated. Coming to the ARASEN study, again, it's a global randomized phase 3 study where patients with good performance status and candidates who can tolerate docetaxel-based chemotherapy. There is 1:1 randomization to the docetaxel plus darolutamide plus ADT arm versus ADT plus docetaxel arm. And the primary endpoint was overall survival. The secondary endpoints were multiple. The time to castration-resistant prostate cancer, time to progression, skeletal events, and other parameters. About 85% of all these patients were able to complete all planned 6 cycles of chemotherapy. And in terms of adverse events between both the arms, we meant to say that the darolutamide arm did not have any other additional side effects compared to the chemotherapy arm. Coming to the overall survival, we can see that the two curves started to separate quite early in the course of treatment. We can see that the median was not reached in the darolutamide arm versus it was 49 months in the placebo arm, that is the chemotherapy arm. And by the landmark time of about 50 months, we can see that 63% of the patients in the experimental arm were alive compared to 50%. That is another additional 13% of patients tend to live compared to the chemotherapy arm. Again, when the same analysis was done in those patients who have got high volume but high burden disease versus low burden disease, in both the groups, the benefit was seen, and the benefit was much higher in the low risk patients, the hazard ratios being 0.62 versus 0.7 in the high risk patients. Coming to the other key secondary endpoints, that is the time to castrate-resistant prostate cancer, we can see that there is nice separation between both the arms, meaning that darolutamide was effective, or it was prolonging the time to transition from sensitive to castrate-resistant stage. Also, there was benefit when patients were offered docetaxel plus darolutamide in terms of time to pain progression, and both of these were statistically significant landmark points. Coming to time to subsequent antineoplastic therapy, again, there was about 60% reduction in the time or risk in terms because of progression leading to subsequent antineoplastic therapy initiation. Coming to the response again, and we can see that there is a progressive increase in terms of proportion of patients who tend to achieve the PSA response. So by about 36 weeks, about 50% of all patients on darolutamide tend to have achieved PSA at undetectable levels. And the response continues as the time duration for darolutamide continues. Also, there is delay in terms of PSA progressions for patients who have been on this combination strategy with darolutamide and docetaxel compared to the chemotherapy alone arm. So there is approx about 75% risk reduction in terms of time to PSA progression. So is the overall survival. We can see that the PSA still remains undetectable at 36 weeks in a significant proportion of patients compared to those patients on the control arm. So darolutamide actually tripled the long periods of no disease progression as well as significant improvement in terms of overall survival. So the time to PSA as well as time to progression to CRPC were better, and ultimately all of this has translated into better overall survival compared to the placebo arm. So at the landmark time point about 48 months, we can see that about 65% of the patients on darolutamide were alive compared to 27% of patients in the placebo arm. So there's about significant difference, I would say near doubling in terms of overall survival at the end of 48 months. And there is about 70% reduction in the risk of death for patients who begin with docetaxel ADT and darolutamide. Again, coming to the responses as well as outcomes in terms of low volume disease, definitely there is significant responses in terms of getting to a point of undetectable PSA. And there is also benefit in terms of time to PSA progression, even in those patients who have got low volume disease. We can see that there is a clear gap between these two Kaplan-Meier survival curves between both the arms. And definitely the low volume subgroup also benefits with the usage of a combination strategy rather than ADT plus novel anti-androgen therapy. So the things to consider and between deciding how we should treat these patients, whether a doublet approach or a triplet approach is to be taken, is the patient's ability to tolerate chemotherapy and whether he is fit to accept or willing to take that docetaxel chemotherapy. And now with the evidence from the presence data clear, I don't think so that there would be any discrimination for those patients who have got low volume or high volume disease because both the groups tend to benefit with the usage of combination strategy. And I think doing chemotherapy, has got protection in terms of removal of these hormone insensitive clones. However, what factors needs to be taken into consideration is again the ability to take chemotherapy, that is the age of the patient, the comorbidities, the performance status, as well as the life expectancy of that patient. And whenever possible, we need to counsel our patients regarding this combination approach right at the time when the patients are diagnosed with metastatic hormone sensitive prostate cancer, because they need to understand that it becomes quite difficult once the patient progresses to the CRPC state, and we have got limited options which are effective when the patients are treated in their particular stage. So the aim of the treatment is to prevent the patients from their transition from hormone sensitivity stage to castrate resistant prostate cancer stage. Thank you.
Thank you, Dr. Nikhil. You went around all the trials which are important for the metastatic CSPC setting. Can you hear me?
Yeah. Hi, Rachna. Thank you.
Yeah. So you have covered most of the important trials in the metastatic CSPC, the outcomes and the other endpoints which are especially specific for the prostate cancer, like the time to pain therapies, the time to progression to a CRPC setting, so which are not commonly seen with the other solid tumors. So thank you for going through all the important trials. I'll invite now Dr. Vishal to give us the next talk. So now Nikhil has told us so many trials, and Vishal sir, my senior, he would be covering a single trial on the role of darolutamide in metastatic HSPC.
Ma'am,
Vishal sir, over to you.
ma'am, I think there is a fluctuation, because it's a heavily raining. So just call me. I think it may take another 5-10 minutes to join back. So, ma'am,
Okay.
meanwhile, can we go ahead with your case presentation?
Yeah, sure. Okay,
I
I'll do
think
that.
sir has joined, it seems. Ma'am, can we check? Dr.
Yeah,
Vishal,
check.
are you there?
I'm there.
Dr. Vishal, sir? Hello, Dr. Vishal? Ma'am, 1 second, ma'am. Let me check it.
Yeah. He's showing online, but I don't know about the connection.
Ma'am, sir is going to be speak, but sir has requested me to share the slides. So give me a minute, ma'am. I'm sharing the slides.
Okay, sure.
Vishal, I think
Hello.
you're audible, sir. Yes. I'm sharing the screen. Just give me a minute, sir.
సంవత్సరాలు ఎప్పుడు వర్క్ ఆగలేదు అంటే బిజినెస్ ఆగలేదు బట్ రెనోవేషన్ సో మీకు బయట వాళ్ళ కన్నా వీళ్ళే ఇంత
Yeah, good evening. Can you hear me?
Yes, sir. Vishal sir, we can hear you.
Yeah, okay. Yeah, a very good evening to everyone.
Who is talking?
Am I audible now?
Yes, sir.
Yeah. So today I'm going to speak about the treatment landscape of the metastatic hormone sensitive prostate cancer. And so, as we have discussed various trials regarding the addition of triplet regimen or doublet, so the treatment landscape has evolved from 2014 till date. First, we have charted trial, stampede trial, which showed the efficacy of chemotherapy plus ADT. And down the line, we have Stampede, Arm G, and Latitude, which has shown the efficacy of ARPS, that is abiraterone, plus androgen deprivation therapy. Then we have trials like Titan, Arches, and enzalutamide, which has shown various like ARPS with ADT. And now we are in an era where we have triplet regimen, like in which we have discussed recently about Arasens and Peace One, which shows darolutamide plus ADT plus docetaxel, whereas in Peace One, abiraterone plus docetaxel plus ADT. So, despite all this ARPS and ADT or docetaxel, this large proportion of patients with metastatic HSPC will progress to hormone sensitive to metastatic castration resistant. Are you able to see my slides? Yeah. Okay.
Yeah, we are able to see, but not
No, sir. Actually, you're not sharing the screen, sir. Actually, I was trying to share the slides. Try once again to share the slides.
అంత ఫోన్ పోయింటాడు మెసేజ్ పెట్టిండు ఆన్సర్ అంతే వాడు తిరిగి
Dr. Vishal, you want me to share the slides?
Yeah, you please, because I'm
I'm
not
sharing the
having-
slides,
yeah.
sir. Give me a minute. I'm sharing
Yeah,
the slides.
yeah, I told Sandeep to share the slides initially.
Once again, sir.
Yeah.
I'm sharing.
అందరు ఏం చేస్తుంటే బురద నెక్స్ట్ వెళ్తున్నాం కొంత రూపాయలు చేసి పడేసి మన
Sir, can you see the slides?
వాళ్ళ ఆడిగాడు తప్పు
Yeah.
Now you can go ahead, sir.
Yeah. So we are discussing about the metastatic hormone sensitive prostate cancer, wherein regarding the Aeronaut study, which actually tells us about the use of docetaxel, whether we can avoid chemotherapy, continue with the doublet, or the trial actually compares ADT plus placebo versus ADT plus darolutamide. So we are in an era where where we can avoid chemotherapy in those patients who are frail enough and who have got particular comorbidities. Can we avoid chemotherapy having the same response as we see with the triplet therapy? So in this slide, we can see various trials have been done since 2014 till date, where they have compared chemotherapy plus ADT or ARPI plus ADT, and finally in newer studies like Arasens and Peace One, they have evaluated the importance of triplet or doublet. So next slide, please. Next slide, please. Yeah. Ah,
Sir, it is taking time, sir. It is okay.
yeah. Okay. So, what is the unmet need we are seeing? So, all these patients, we should see for efficacious treatment that offers a differentiated and improved safety profile in metastatic HSPC without adding significant toxicities. Either we can avoid chemotherapy altogether. So we have seen Arasen's phase 3 study, which has shown efficacy in metastatic, in low volume or high volume disease. And darolutamide in combination with ADT would provide efficacy with a favorable safety profile in this Aeronaut phase 3 trial has showed we can safely avoid chemotherapy and go with the doublet with uh, darolutamide plus ADT. So darolutamide plus ADT with docetaxel is the standard of care in Arasen study, but Aeronaut was designed to evaluate the doublet treatment like darolutamide plus ADT versus ADT with the placebo for this metastatic hormone sensitive disease. So Aeronaut study actually randomized patients in a 2:1 ratio, wherein darolutamide with ADT was given 2:1 with placebo with ADT. The primary endpoint was radiological progression-free survival, and secondary endpoints were overall survival, which is the key secondary endpoint, and time to initiation of subsequent antineoplastic syndromes, time to CRPC, and time to PSA progression. So after that, they allowed the crossover. So after the study was initiated, 100% crossovers were there. And due to both the darolutamide plus ADT, placebo ADT were equally, all this were matching. Like Asian population were substantial. That is almost 1/3 of the patients were Asians, and so de novo disease were around 70%, and recurrent patients were around 20% in both the arms, and other parameters were equally matched. So if we see uh, the Asia Pacific region, so all the regions were equally represented, like India, China were around 15% of each in both the arms. So if you see the darolutamide plus ADT, you can see the curves were separating as early as 3 months. Yeah, could you change the slides, please?
Sir, it is taking some time. Changing slide.
Yeah.
Yes. There is a fluctuation in the internet, sir.
Yeah.
Yeah, I think it is changed, sir. I hope.
Yeah. So you can go to the next slide, please.
It is already. Okay, sir.
Yeah. So if you see the Kaplan-Meier curve, the so you can go to ninth slide. Ninth. Yeah, next slide. Yeah. So if you see the darolutamide plus ADT, you can see the curves separating as early as 3 months. At the median overall, I mean, 24 months, we can see the darolutamide plus ADT has 70.3, and without without reaching the median thing, and whereas placebo plus ADT median was 25 months. So this is no, the overall median was not reached at 2 months with the darolutamide plus ADT. So the benefit of darolutamide plus ADT on radiological progression free survival was consistent across all the subgroups, and if you see, it has shown uh, good response in both high volume as well as low volume disease, and more so in the low volume disease with a hazard ratio of 0.3. And if you see the secondary endpoints, uh, overall survival was comparatively better compared to placebo. And time to metastatic castration resistant prostate cancer. So 34.5% versus 64. So, and time to progression. So across all the parameters, darolutamide plus ADT showed a good response. But at the time of primary analysis, worst data was still immature, and the patients will be followed for survival. And time to metastatic CRPC, the hazard ratio was 0.4, and the time to pain progression, and it was also got an impressive hazard ratio of 0.72 with a median survival of 29.9 compared to median of 13.8. So time to PSA progression, and with the percentage of 62.6 versus 18.5. If you see the overall patient achieved undetectable PSA with darolutamide plus placebo. If you see both in high volume disease as well as in low volume disease, darolutamide plus ADT fade well, more so in the low volume disease rather than in the high volume disease. Next slide, please. So subsequent life-prolonged anti-cancer therapy. If you see the patient with darolutamide plus ADT had a lesser percentage of going to subsequent anti-cancer therapy compared to placebo plus ADT. So the incidences of adverse events, if you see the both groups have the similar AE, so there is not much toxicity with the addition of darolutamide. And even though serious adverse events were comparable in both the groups, that is 23%. And and adverse events leading to permanent discontinuation, actually it's more in the placebo rather than in the darolutamide. Maybe this was due to the disease progression also, but darolutamide itself did not increase any incidence of adverse events. If you see, the most common AEs were low and similar between the two arms. If you see fatigue, it is a little bit uh, higher in the placebo rather than in the. It means that the addition of darolutamide did not cause any increase in fatigability, and remaining other like anemia, arthralgia, urinary tract infections, all the back pain, all if you see all the most common events, it was comparable in both the groups. And other events like hypertension, cardiac events, or skeletal events, including cognitive. So, in all the groups, uh, both the placebo plus ADT versus both are comparable without adding much of toxicity between the two arms. Uh, so, if you see the quality of life, darolutamide extended the median time to deterioration by a score of 5.1 versus placebo. And darolutamide is the only, first and only androgen receptor inhibitor to demonstrate clinical meaningful delays in brain pain progression as well as overall well-being of the patient. Next slide, please.
Basically,
So, in the darolutamide doublet study, they have evaluated different parameters like physical well-being, social family well-being, emotional, and functional. So, if we see all the parameters, and when compared to placebo plus ADT, all the events were lower. Like quality of life was better, emotional well-being, functional well-being. Were comparable with the hazard ratio of less than 1. Like in the social and family well-being, it is 0.79. In the functional well-being, it is 0.78. So if we compare all those parameters, the ADT plus darolutamide fared well. So if we conclude, the darolutamide plus ADT showed significant improved radiological PFS in comparison with placebo in metastatic HSPC. It showed benefit across all the secondary endpoints, and it was associated with a deep PSA response. And it is the only first and ARPI to demonstrate clinically meaningful delays in pain, overall well-being, including social, family, functional, urinary symptoms, and it has showed a favorable safety profile. Darolutamide plus ADT without docetaxel should be the an additional standard of care in patients who are frail, who are not fit for chemotherapy, and this is also a acceptable therapy in patients who cannot tolerate chemotherapy. This is what the aeronaut study has showed, and yeah. Thank you for your patient hearing. Would be able to take any questions we have.
Thank you. Okay, probably the composite అవడానికి ఇంకా ఇంకొకరు ఈయన స్ట్రాంగ్ బ్యాక్గ్రౌండ్
Thank you, Vishal sir. Yes, Sandeep, please.
ఆయన అటెండ్
Ma'am,
అయ్యారు
please proceed, ma'am.
Thank you, Vishal sir, for explaining in detail about the RSN study
మనలాంటి
and the role of darolutamide in metastatic HSPC.
ప్రాబ్లం కాదు
Sandeep, can we proceed with the next case discussion?
Yes, ma'am.
The
Please.
presentation.
Yes, ma'am. Please go ahead.
I'll share my screen. So I'd be presenting a case which we have treated in our hospital, and after that, I would request Dr. Nikhil and Vishal sir to please stay so that we can discuss a few questions relevant to our practice in metastatic hormone-sensitive prostate cancer.
వాళ్ళకి ఇస్తే అది కరెక్టే కదా ఎప్పుడైనా వాళ్ళు ఫుల్ టైం ఎవరు ఉంటారో వాళ్ళకే పెడతారు కదా ప్రొఫెసర్ పెడతారు ఇంకౌజ్ ఏమంటాడంటే
Is my screen visible?
నా మెడికల్ లేడీ
Yes,
Yeah,
sir.
it's visible.
Okay.
Can the
So-
other participants please?
ఏం మార్చదు
Yeah.
Vishal sir, I think you can put on mute, sir.
So I will be discussing a case of metastatic CSPC only because today our discussion is for metastatic CSPC. This is a case from our own hospital. He's a 67-year-old male who is a known hypertensive and hypothyroid on regular treatment. He presented 2 years back to us with the urinary symptoms, the urgency, hesitancy, which is one of the commonest presentations of the prostate enlargement. He was initially evaluated with an ultrasound abdomen. They told that there is a lesion in the prostate. The serum PSA was more than 151. But with this evaluation, he was not further treated. He was not further evaluated with anything else. He was lost to follow-up. He was informed that there is a lesion in the prostate, but he did not get any further evaluation or any further treatment for this. And this was all done outside. After that, again, 8 months ago, he presented with increased urinary symptoms, and he was evaluated with the that is a section of prostate, and also he underwent a bilateral orchiectomy together. This was also done outside, and then he came to us. So the TERP chips were brought to the hospital for the review, and it was reported as an acinar adenocarcinoma of the prostate, Gleason grade group 4. So the grade group 4 lesion, and then we did a PSMA PET CT. Because the disease burden is high, the PSA was very high. It has shown a locally advanced PSMA positive prostate tumor with nodal and skeletal metastasis. If you can see here, the skeletal metastases are there in multiple bones. So this is becoming a high volume disease with C7, D1, D2, D3, ilium, right acetabulum, ischia, pubic rami. Everywhere there are metastases. So more than 4 bone metastases along with nodal disease with a locally advanced prostate malignancy. So this patient is diagnosed with a metastatic castrate-sensitive prostate cancer, high volume disease, Gleason grade group 4, and with known comorbidities of hypertension and hypothyroid, but still his performance status was ECOG 1. So with this diagnosis being a high volume disease, we plan to start on triplet therapy because the performance status is good. So we generally prefer triplet therapies in a high volume, high risk disease in a patient with a good performance status, and also comparatively younger population rather than the older population of around 80 to 90 years where we don't want to give them the toxicities of triplet therapy. So the younger population, for the prostate, the younger population is actually 60s, whereas for the other solid tumors, it will be 30s or 40s. But for the prostate cancer, 60 is still a younger age group, 50s, 60s are the patients, and with a good performance status with controlled comorbidities is a population which we would consider using a triplet therapy. And also based on the disease characteristics, whether it is a high volume, low volume, we have seen Dr. Nikhil discussing about this point of low volume disease. So the majority of the data which we have is in the high volume disease, and also we know our aim for triplet therapy is mainly to attain a rapid responses for symptomatic patients. So for this patient also, as he was a delayed in diagnosis of 2 years and with the symptoms, with so many bone metastases and with a good performance status, we thought we'd start with the triplet therapy. So we have started him on injection docetaxel 75 mg per meter square, which was given once in 3 weeks. Then we have tablet darolutamide 600 mg twice daily. And the patient already underwent a bilateral orchiectomy. So the surgical castration was done, and hence no other further medical castration was used in this patient. So he was responding well to treatment. Initial value of more than 150 has started coming down within 1 month of treatment with the triplet regimen. It was around 16, and after 3 months, it was 0.76, 5 months, 0.3, and by 7 months, we could attain a very good control of the serum PSA, 0.009. So the patient was very well responding to treatment, not just the PSA values, clinically also, he was a lot better symptomatically, he has improved, and he was tolerating the treatment well. He did not have any side effects, major side effects, I would say. Occasionally, he used to complain of grade 2 diarrhea, especially for the first 6 months where we were giving him the docetaxel, and also complained of mild alteration in the taste. But other than this, he did not have any grade 3 or grade 4 adverse events. So he was very comfortable. His quality of life has also improved well with the treatment. So we have completed 8 cycles of docetaxel. He's continuing tablet darolutamide, tolerating the treatment well, and this PSA levels in the latest follow-up were also less than 0.01. So a well-controlled metastatic CSPC with the triplet regimen, where we discontinued docetaxel after 8 cycles. Docetaxel, we can range it from 6 to 12 cycles based on the tolerance and based on the symptom response. So we have stopped at 8 cycles, but if you expect a better responses, you can still continue up to 12 cycles also. If you see, majority of the trials have used up to 12 cycles of docetaxel in the CSPC or the CRPC setting. So it depends on a case-to-case basis that whether you want to go 6 cycles or 12 cycles of docetaxel. But beyond that, continuing darolutamide is also necessary in order to keep the disease under control. We don't have a definite treatment for any of the ARPIs now. So it is always an indefinite treatment till progression or till tolerance. So as this patient was tolerating treatment well and he had a good response to the PSA, we have come down on the docetaxel with 8 cycles. We have stopped there and continued darolutamide. So this is for the case presentation.
Yeah, Dr. Rachna, can I add the same? Like,
Yes, sir.
I have,
Please, sir.
I had a similar case wherein the patient was around 80 years, but he was very fit. So we
Okay.
have started, he was having high burden of disease. So we have added triplet regimen. And after 4 cycles, we have done a scan, PSMA scan, which was showing a very good response, and the patient was fit. So we continued the same triplet regimen till 10 cycles. So, and the patient tolerated very well. So because his age, so we stopped at 10 cycles and we are continuing him on darolutamide plus ADT relugolix. So the PSA levels are not detectable and the patient continues to be in complete remission as of now. Yeah.
Yes, sir. Many patients actually we are afraid that they might not tolerate because it is a triplet combination, but majority seem to tolerate well with the triplets also. We don't find much toxicities in our clinical practice is what I feel. Even the age, as you told, 80 years tolerating. So did you use the 2 weekly docetaxel or the 3 weekly docetaxel?
I used the 3 weekly, but I just reduced the dose from 75 to 60 mg. He was tolerating to 100 mg for 3 weeks. Yeah, he
Okay,
was
okay. Because
tolerating 100 mg 3 weeks. Yeah.
yes, yes, sir. Many times we do the 2 weekly regimen also, no, sir, for the more elderly patients for the docetaxel
Yeah.
when we are giving.
Yeah, we can give 80 mg 2 weeks or so. We can give.
Yes, sir. Yes,
Yeah.
yes, sir.
Yeah.
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 So moving on to the Q&A session. So this is my presentation for the Q&A session. It's visible, right, sir? The slides.
Some slides are visible, but we can't see both of you. I don't know.
Sorry.
We can, can you switch on your camera, ma'am? Already it is there on camera. Yeah, now I can see, ma'am. Yeah, now I can see that. Thank you, ma'am.
You can see. Yeah. Okay. So the slides are visible, right, Sandeep?
Yes, ma'am. Visible.
Yeah. It's visible. Yeah.
Yes, sir. Dr. Nikhil, you're there, right?
Yeah.
So this is the treatment paradigm which we have for the treatment of metastatic HSPC. Initially, it was only ADT alone, which became insufficient. Now came the option of doublets. The ARPI doublets established an important role in the management of metastatic HSPC with the Enzamet, Arches, and Titan trial. Then we have the PEACE-1 and Arasens, which we have shown the triplet regimen, which we were discussing the cases with triplet regimen has improved a lot of survival outcomes with the triplet in the patients with metastatic CSPC, especially for the fit and high volume patients. And now we have a data for the darolutamide in the doublet, with the doublet only, not the triplet, that is the Aranot, which Vishal sir has recently discussed us to us about the Aranot study. And now with all this data which we have, how are we going to select? How are we going to decide what drug you want to use in your day-to-day practice? Because that is the most important thing which we have to discuss. So, Vishal sir, can you please take this question? Which patient phenotypes most clearly tip you to use doublet versus using the triplet intensification?
Yeah. In metastatic HSPC, whether it's a high volume or low volume, or the patient, the fitness like cardiac comorbidities, renal impairment. So it does play a part, and because age is not only the criteria, if the patient is fit enough, and we can give triplet therapy in, I mean, low volume disease as well, because in piece one, the responses with the low volume also were better. And it's not only about I mean, the age, but if the patient is frail enough and is not fit for chemotherapy, we can give doublet in high volume disease as well. Yeah.
Yes. Dr. Nikhil, what is your patient population where you would prefer a doublet?
A doublet. So if the patient has got multiple comorbidities, has got poor performance status, someone who is not willing for chemotherapy. So these are the patients where I would do ADT plus novel anti-androgen therapy.
Yes. So especially patients who are unfit or who we think that they might not tolerate the toxicities of chemotherapy, is that subgroup where we all prefer to use a doublet compared to the triplet intensification. But for majority of the patient, wherever we can, wherever they think the patient can tolerate, most of the clinicians would prefer to go with the triplet intensification than your usage of doublet. So when abiraterone or enzalutamide combinations feel suboptimal, what are the most common clinical or practical triggers where you feel that these combinations of abiraterone or enzalutamide are suboptimal? Whether it is the steroid requirements with abiraterone or the cardiometabolic risk with abiraterone, CNS related concerns with enzalutamide, or the adherence to the drugs. Vishal sir?
Yeah, as we have seen in the previous aeronaut study and Aerosens, the cardiac or the endocrine abnormalities with the darolutamide are minimal compared to abiraterone and enzalutamide. So when you're using abiraterone, we need to use steroids, which may impair the glycemic index. So the patients who are, I mean, who have some kind of cardiac or endocrine abnormalities, it is better to go with darolutamide rather than abiraterone or enzalutamide.
Dr. Nikhil, your thoughts for this?
Uh, Agree to the majority of what Dr. Vishal has said. Uh, uh, but in terms of steroid milligram once daily, shouldn't be that challenging, except when we have got comorbidities where one particular anti-androgen cannot be prescribed. Like someone has got CNS side effects or CNS tendency for seizures where we don't use enzalutamide, or someone with cardiac disease, fluid retention. So those are patients where we don't get to use abiraterone. So irrespective of the background comorbidities, I think darolutamide is one where it can be used in a vast majority of patients.
Yes, and even the drug-drug interactions also, we have seen various studies. Both of you have shown that the drug interactions are lesser with darolutamide compared to enza or abiraterone, which are cytokine P3 inhibitors. So that is also an important point, especially because we are speaking of a population which is mainly on many drugs. Other than the CA prostate related treatments, they are already on various other drugs for their comorbidities. So this population where the CA prostate is most predominant, the drug-drug interactions also play an important role for us to feel that maybe yes, we have to go choose a drug which has lesser interactions and which will not interfere with the day-to-day life of the patient who is already accustomed to so many drugs. And adherence, yes, adherence is also an important thing. When you want to give more number of pills, it will become a problem for majority of the patients. So, Dr. Nikhil, which Aranode strengths most impact adoption versus the currently approved doublets which you already have?
So definitely the terms in terms of responses, time to undetectable PSA levels, time to progression to CRPC or subsequent therapies, are all these factors which reassure us that we should use the effective agent. Even so, if we use a doublet combination, that we should use a better agent rather than keeping it towards the end. So I think these are certain parameters which ultimately decide the overall survival for these patients.
Vishal sir, do you consider the Aranode's PFS? You have already described in detail about the outcomes of Aranode. The hazard ratios, are they comparable to the other trials like the Arches and Titan? And does
Yeah.
this comparison affect the first line confidence of starting a particular agent?
Yeah, if we compare the Titan arches, the hazard ratios are a little bit better in the error node, and the median OS is not reached actually in the error node study, and all the secondary endpoints like overall survival, time to progression, the quality of life, and to transformation to CRPC, they're all, better compared to these Arches and Titan trials.
So the hazard ratios are cross-trial comparisons, but still they're all almost similar with slightly better preference for one outcome with the one drug than the other. For the
Yes.
overall survival for around, if you speak, it's immature, but it is looks promising with a hazard ratio of around 0.8. So if we
Yes.
get a stronger overall survival data, then maybe we would have a clear choice that this drug is preferred over the other drug. But maybe in the present scenario, keeping the other things in mind, like the comorbidities, the drug-drug interactions, darolutamide scores over the other drugs because of the associated toxicities with these other areas compared to darolutamide. But the hazard ratios, as Vishal sir was saying, is almost comparable to all the other trials also.
Yeah, we
So,
need
Dr.
to
Nikhil?
wait till the
Yes,
OS data matures, maybe.
yes, sir.
Yeah.
That gives us more confidence in selecting a particular ARI compared to the other ARIs if we get the overall survival data.
Yeah, yeah.
Dr. Nikhil, how do the volume data clarify? I know you have stressed this point when you are presenting the trials. So, do you really see that the patient has a high volume, or irrespective of the volume, you want to use a triplet regimen?
No, I also believe in practice that I wish to do triplet therapy for a majority of my patients wherever feasible. If the patient is fit, I always counsel, irrespective of the volume of disease, for a triplet therapy.
Vishal sir, what about you?
Yeah, yeah.
Based on the volume.
Obviously, triplet scores better even in the low volume disease as well. But if the patient is fit enough without any comorbidities, we would prefer triplet therapy over doublet. Yeah.
So coming to Arasens data also, which we have, the low volume is included in Arasens. The hazard ratio, if you see, is around 0.64. And the only problem was the confidence interval was crossing 1 for the low volume metastatic HSPC. So because of the confidence interval crossing the 1, if you see the data or you see the guidelines, they recommend that you give triplet in a high volume patient. But still, even the low volume patients do benefit with the triplet regimen, especially those patients who have a rapidly rising PSA or who are very symptomatic for the disease, even though it is a low volume disease, and you think the patient is fit enough, triplet regimen still holds good even for the low volume disease. So, as both Dr. Vishal and Dr. Nikhil have told, that volume doesn't decide whether you want to go only for a triplet or doublet. It is the symptoms, it is the patient's condition, and it is the comorbidities which the patient has, which will help in choosing whether you want to go for a doublet or a triplet regimen. And Dr. Nikhil, we have discussed this again, the same thing, but a slightly different question. Who are ideal candidates for darolutamide doublet therapy compared to the alternative regimens? Not doublet versus triplet, but doublet versus the other ARIs, or chemotherapy versus this.
Darolutamide doublet, I would say a sophisticated patient who want least complications or who wants his quality of life to be preserved, who is able to afford. So I think that's the patient for whom I would suggest ADT plus darolutamide. Otherwise, based on other comorbidities, whichever anti-androgen suits, I would suggest, yeah. And for a fit patient, a triplet regimen.
Vishal sir, your ideal candidate for darolutamide doublet compared to the other options we have for a metastatic CSPC.
Yeah, apart from cost constraints, as we have seen, the patients who are having CNS symptoms like seizures and like the patients who are having cardiac comorbidities where we can't use ENZA. So, in these patients, darolutamide scores above this, and it has got a good. I mean, the secondary endpoints. Like quality of life, everything. So these patients are the ones who may benefit from darolutamide. Yeah.
So yeah, cost, if cost is almost equal to the other drugs which we have available, I guess darolutamide is the ideal choice for most of the metastatic CSPC, is what both Dr. Vishal and Dr. Nikhil are pointing out. So the cost is not an issue. majority of the patients do prefer to have a good quality of life, and also they don't want side effects with the treatment which we are giving for a malignancy. So darolutamide scores over in that point of being a safer drug compared to the other alternative regimens which we have for the metastatic CSPC setting. And Dr. Nikhil, again regarding the drug-drug interactions, do they actually change your decision when you are planning treatment for the metastatic CSPC setting for Indian patients?
Yes, what I would do in practice is usually enter the uh, polypharmacy or the drugs which the patient takes along with the anti-androgen they take and check for any cross interactions. So I would do that in practice, especially for someone who takes more than 3 or 5 pills per day, which they take it for other medical conditions. So that would definitely influence my decision in terms of picking up an anti-androgen.
Vishal sir?
Yeah, yes, Rashna. In elderly patients, we see most of the time either diabetes, hypertension, hypothyroid. Some of the other comorbidities are essentially present. So, as Nikhil rightly pointed out, we need to see the polypharmacy, how many antihypertensives, how many anti-hypoglycemics the patient is using, and we need to check for drug-drug interaction and which darolutamide has got a least drug-drug interaction. So in these patients, I mean, this darolutamide really scores out.
Yes, sir. When we check in our clinical practice, even the least expected drugs do have interactions. Like our routine using PPIs, the azoles, if you're using it, they also have a lot of interactions with the various other drugs which the patient is on. So when we check it out, we know that yes, this simple drug is also causing some interaction with the other treatments which you're planning for the patient. So when we are using drugs like the darolutamide or enzalutamide or abiraterone, especially for a patient who is on polypharmacy, it actually makes a major decision for us to choose a drug which is most suitable for the patient with the least drug interactions. So the last question, how should Indian oncologists or uro-oncologists approach the treatment sequencing so that we can preserve options for the castrate-resistant prostate cancer stage? So we have much strong evidence for the sequencing, but your opinions, Vishal sir?
Okay. So, if you compare all the trials, Aranot, Arasens, Enzamet, so whereas Arasens and Peace always advocate triple drug regimen, and whereas Aranot, Titan, Enzamet, these are the doublet therapies. So, if you see a fit patient who is eligible, always the triplet regimen is the go-to choice. And when the patient has comorbidities and not fit enough frail patients, the doublet is a choice. And choosing the ARPS, we should choose the drug which has least toxicity to the concerned organ, like we have to see CNS, cardiovascular status, and choose our drug. Yeah.
Dr. Nikhil, what about your sequencing options?
I think the way to go is triplet therapy. But what I would get to see in clinical practice would suggest the uro-oncologist is not to take the treatment choice into their hands. Sometimes because of their concerns or their interpretation of the side effects of chemotherapy, they start with anti-androgen at their own clinic, and by the time patient tends to have a progression in terms of PFS, that is when they refer to us for chemotherapy. So that is where I think some of the patients might lose the benefit of the initial option of triplet based therapy. That is one area where certain improvement has to come. But otherwise, in terms of medical oncologists, I think we are all well aware of the available combinations, the best agents which are available, and how to choose the appropriate treatment for our patients in clinic.
I agree with you, Nikhil, on this point, especially because the majority of the patients whom we see in our institute are CRPCs only, not CSPCs, because the CSPC stage is being managed by the uro-oncologists or the urologist who are not aware of the advances which are happening, and they are still at the stage of only using ADTs. They only put the patient on ADT, or if they're doing a surgical castration, the patient is on bicalutamide, which we almost stopped prescribing. By majority of the medical oncologists have stopped prescribing bicalutamide for any of the prostate cancer patients now, except to overcome the flare for few of the patients, which is given for a week or a 2 weeks regimen. But other than that, majority of the medical oncologists are not using bicalutamide, but our patients whom we see in our clinic are coming to us with bicalutamide being prescribed for the past 2 or 3 years and landing to us only with the CRPC stage. So hence the amount of patients in the CSPC stage are not being managed as appropriately as required with the newer regimens, with the triplet or the doublet regimen, which would have been more appropriate for them. So if you're not starting a treatment initially at the CSPC stage properly, then the point of sequencing doesn't matter, because unless you start with the correct regimen, then comes the discussion of sequencing. So if you're not starting with the appropriate regimen initially, then whatever we do in the later lines doesn't have much impact. It's always better to start with the best approach initially and then sequence it properly. So sequencing, we need some more data. Which drug first, which drug later, whether DARA first and followed by abiraterone next. We don't have proper data. We do have some studies for enzalutamide abiraterone sequencing, some of them showing a positive impact of abiraterone followed by enzalutamide, but not with enza followed by abiraterone. And other trials showing that either you do abiraterone followed by enza or enza followed by abiraterone, you don't have much evidence to say that one sequencing is better over the other. For darolutamide also, and even for the apalutamide, which one is preferred over the other in the next sequencing order, we don't have a solid phase 3 study to say that you can sequence in this order. But in the clinical experience, we all of us are doing the sequencing based on the patient's condition at that particular point of time, the comorbidities and the fitness of the patient, and what were the toxicities which the patient faced with the prior drug which we have already used. So these are all the factors which we take when we are sequencing the therapies, and also incorporate not just the oral medications, but we also try to incorporate docetaxel and cabazitaxel in the sequencing along with the ARIs, so that the patient gets the maximum survival with the proper sequencing. And along with all of these things, we also have to sequence the lutetium PSMA, which is also a very good therapy for patients who especially only have the bone metastasis without any visceral metastasis. So sequencing is not just for the Arana, Taracens, Enzamet, Peace, and Titan. But once if it is in the CRPC setting, we have to sequence with lutetium, we have to sequence it with the chemotherapy also. So thank you, Vishal sir, and thank you, Dr. Nikhil, for being active participation and presenting the data on the treatments of metastatic CSPC. Sandeep, thank you once again, and over to you.
Thank you so much for your time, ma'am. So my sincere thanks to, I think before that, let me check chat box if any questions are there, ma'am.
Yeah, sure.
Ma'am, I don't see any questions or comments in the chat box. So with this, we can conclude the session. My sincere thanks to Dr. Nikhil sir for presenting the data analysis in a triplet combination, and my thanks to Dr. Vishal sir for presenting the data in doublet. Note, and my thanks to Dr. Rachna ma'am for chairing the session and presenting your case. With this, we can conclude the session, ma'am. Thank you. Good night. We can technical
Thank
team
you.
can end up.
Thank you, Sandeep.
Thank you, ma'am.
Thank you, Rachna, for moderating.
Yes, sir. Thank you, sir.
Thank you.
Bye. Bye, Nikhil.